We are now going to turn it over to Dr. Susie Lee, who's an orthopedic principal house officer at Toowoomba Hospital, also just like Dr. Johnny. So she is a medical doctor, but she, in addition to spending half of her week training to be an orthopedic surgeon, the other half of the week she spends with us over at CFM, also part of SIMPLE Hub, and she is researching ways to improve patient outcomes and reducing hospital waste using innovative 3D printing techniques and personalized medical devices. So she'll be presenting here on a novel technique for the surgical management of scaphoid non-union. Over to you, Susie.
Thanks, Molly. I'm just going to share my screen. Can everyone see the PowerPoint?
Yep.
Perfect. So today I'll be presenting on my project called Developing a Novel Technique for the Surgical Management of Scaphoid Non-Union. I'd like to acknowledge country, and these are my disclosures. I'd like to touch on this collaboration between the University of Southern Queensland and the Darling Downs Hospital Health Service. So there's been a position made from 2023 until 2025 for one clinical orthopedic PHO to also undertake a part-time research role in the MedTech part of the SIMPLE Hub committee. Dr. Michael Roberts did it last year. I was fortunate to do it this year, and Amy will be following on next year in this role. A week in the life as a part-time ortho PHO and part-time research fellow is spending half of the week doing operations, seeing patients in clinic and ward rounds, and also spending the other half doing research and manuscript editing, as well as having the opportunity to go to a lot of different conferences as well. So I've been fortunate to participate and present some of my research at the Australian Orthopaedic Association annual scientific meeting, as well as a Queensland branch meeting. And that's Dr. Michael Roberts and myself at the branch meeting being able to present some of our research done through SIMPLE Hub and CFM this year. I'd like to go through the background of what scaphoid non-union is, an overview of 3D printing and different bone grafts, and then talk a little bit about the study aims, the work to date, as well as the study design. Then moving on to sort of the cutting jig trials, the proof of concept studies, and future directions of the scaphoid project. I'd just like to mention that this presentation does include photos of human cadavers and specimens, so just be aware. So scaphoid fractures are a common injury, and it's the most common bone to be fractured in the wrist. This is a scaphoid here. It would look like a kidney bean, accounting for more than half of all wrist fractures. Despite adequate and appropriate management, unfortunately, 10% of these go on to non-union, which means that the bone has failed to heal. This results in a lot of pain, reduced grip strength, and reduced range of motion. Unfortunately, this scaphoid non-union pathology affects a lot of young, active individuals in their late teens to early 20s, when they're sort of in the prime time to be working in society. This can ultimately lead to things such as a humpback deformity, instability of the wrist, as well as sort of advanced osteoarthritis, as shown in these three images. 3D printing has been well utilized in other orthopedic subspecialties, such as oncology, where they use jigs, as shown here, to define the resection safety margins, as well as joint replacement operations, where they use a lot of navigation to make the cuts on the femur and the tibia, as well as trauma surgery, shown in this bottom picture, doing a lot of pelvic fixations. The use of surgical navigation with virtual reality and real-time optic tracking has also been an evolving part in the orthopedic department. Specific to scaphoid fractures, the current uses of 3D printing have only been researched in acute or very minimally displaced fractures, which don't have a big risk of non-union. A lot of these include making molds for wire insertions, as well as replacing the whole scaphoid bone. Research in this department has shown that it reduces the angular deviation, it reduces the radiation exposure and the overall operating time. A gap in literature is that there's no surgical cutting guide that has been developed for any iliac crest bone grafting or chronic scaphoid fractures. These are some of the examples. So a wire is placed down into the wrist, and a 3D printed plastic model is printed to sort of guide the trajectory of those wires. And there's an example of sort of the molding using CT scans, as well as fiberglass casts. This is some examples of the use of titanium and different models and guides for replacing the whole scaphoid as well. I'd like to move on to sort of the bone graft. So when scaphoid non-union happens, it leaves a really big deformity which can't be just filled up by the body. So there needs to be a sort of bone graft, which can be vascular or non-vascular. It can be an autograft, which comes from the patient in a different body part. It can be an allograft. It can be synthetic. And you can harvest these grafts from different places like your pelvis, iliac crest, your distal radius, a part of your wrist, and a medial femoral condyle, a part of your knee. And there are different ways of harvesting all these bone grafts. The gold standard that has been shown in literature over the last 30 years is to take a bit of bone from this top part of your pelvis. So this is the front, this is the back, and you make a little cut on the top part here. And that actually results in being able to grab 3 different types of bone. So soft bone, hard bone, and sort of mesenchymal growing bone. However, a complication of this type of graft is that it can result in a lot of pelvic pain at the site of the bone graft. The aims of this project is there's lots of issues with the current clinical practice, which involves performing a freehand osteotomy. So basically guessing how much to take. This lacks accuracy. It's not reproducible and unfortunately not customized to the anatomy of that patient. And for a lot of young surgeons, this can be a very steep learning curve to adopt. So the overall aim is to create a patient-specific surgical cutting guide and aims to harvest a non-vascularized wedge of bone to replace this deficit and void in the scaphoid. This hopes to reduce operating time, radiation exposure, improve anatomical and radiological accuracy, reduce the number of revision operations needed, and also enable patients to return to work earlier. I'd like to cover the work that has been done over last year and this year. So we've done a literature review. We've analysed the symmetry of scaphoid bones using a high resolution CT. We've looked at assessing the reliability of common measurements to assess this deformity. And our ultimate goal is to make a patient-specific surgical cutting guide. So starting with step 1, the literature review, Michael started this last year and we've sort of refined it. Basically looking at a systematic scoping review of patient-specific devices in the management of chronic scaphoid non-union. So there's been a lot of research in acute fractures and those that don't go on to non-union, but this is the first study of its kind to look at chronic fractures. So out of the 505 studies, we've narrowed it down to 12 articles, which involve looking at devices such as guides, implants, and preoperative planning. Overall, the studies show that patient-specific devices are not inferior to standard surgical practices and actually has shown to reduce the operating time, improve radiological accuracy, and anatomical accuracy as well. This is a summary of the papers that were included in this study. So things such as the surgical guide, a reduction guide, the percutaneous wire guides, as well as whole implants and screws. This manuscript is currently under review in the Journal of Frontiers of Medical Technology. Step 2 involved analysing the symmetry of the scaphoid bone in hopes that if we can take a CT of the unaffected wrist without the broken bone and actually use that to invert it and see if we could use those dimensions to fill the actual accurate dimensions of the deformity. So what we did is we took a high resolution CT of 30 healthy participants, which led to CT scans of 60 scaphoid bones. We use a vitreous software to extract the isolated scaphoid bone and analyze the volume and geometry of these bones. Overall, this study showed that despite hand dominance, there's no difference between size and no difference in the scaphoid volume, length, or surface area. The only significant difference was that the female scaphoid participants had a smaller volume and surface area compared to the male counterparts. Overall, this is the first study to compare the volume and geometry of bilateral scaphoids in left-handed individuals. In the past, it's only been sort of studied in right-handed dominant patients and individuals. And overall, it supports the utilization of these high-resolution CTs to plan for the affected side by using the uninjured side. This manuscript has been submitted to the European Journal of Radiology. Now, Step 3 involved looking at the reliability of some common scaphoid deformity measurements. So 4 orthopedic doctors from Toowoomba Hospital underwent 2 one-hour sessions looking at these 3 measurements: the height-length ratio of the scaphoid, this dorsal cortical angle here, and the lateral intrascaphoid angle. Overall, 73 patients were analysed, and in line with the current literature, the height-length ratio was the most reliable in assessing the scaphoid measurement, followed by the dorsal cortical angle, and the lateral intrascaphoid angle was the least reliable. This manuscript will be submitted to the Journal of Hand Surgery, European volume. Now, this is probably the final sort of goal and aim of the scaphoid project, which is making that surgical cutting guide. So the methodology is basically taking a high resolution CT of the unaffected wrist in small 5mm slices, then exporting this using CAD software and preoperatively planning by assessing the 3D geometry of that affected and unaffected bone to know exactly the dimensions of what void we have to fill, followed by printing a patient-specific customized surgical cutting guide, and followed by looking at a proof of concept and preclinical study with the hopes of translating this into a human population. We have based the current jig on recommendations with parameters. So basically, a jig has to be at least a minimum of 5mm thickness, as well as accounting for 0.4 to 0.8 millimeters offset to allow for the lining across the bone called the periosteum as well. A most recent mechanical study by Kwan et al. Has shown that the ideal jig thickness should be around 15 millimeters, with the cutting slot being around 110% to allow for the oscillations of the bone saw. In terms of the wires that keep the jig onto the bone, they've recommended a 1.6mm K wire that should be at least a centimeter apart to enable a strong stability and base of support for the bony resections. So we've undergone 15 trials to date for the jig, which is comprised of this base and these cutting slots, as well as slots for the K wires. And it's made up of a polylactic acid PLA biodegradable material, and we're still in the process of refining the locations of the cutting slots, as well as the K-wire fixation methods to allow for the best contact with the bone, taking into consideration that there are other structures like nerves and blood vessels. So the proof of concept study is the first part of looking at the surgical cutting guide. So what we've done is reprinted 3 male hemipelvises and 3 female hemipelvises. What I like to show here in this photo is how small this jig is compared to some of the other devices shown, like the drill, the wires, and the bone saw. As you can see, this is the front of the pelvis and this is the back. The jig is affixed to the front of the pelvis using these wires, which come in at a 30-degree angle And you can see how the jig is well sort of affixed to that side of the pelvis. I'd just like to show you this video demonstration here. The thing I'd like to highlight is instead of the saw going in perpendicular to the base of the jig, we want it to go in at a 30-degree angle to account for some of the blood vessel and nerves that wrap around the front and down this side of the pelvis. So once the proof of concept study is done with the pelvises and the wrist models, the hope is to translate this into a preclinical animal model. Research has shown that the best representative pelvis model that's most similar to humans is that of a sheep girdle. So moving forward, we'd like to also distribute a survey looking at the preferences of hand surgeons on sort of bone graft harvesting and scaphoid non-union. And the aim of this is we know that the gold standard is using a bit of the pelvis, and but we want to see what clinicians do in a day-to-day practice and see what works for them. So this is currently awaiting an ethics review, and it will be distributed to the Australian Hand Surgery Society, and then we'd like to publish those results as well. The ultimate goal is to liaise with the Therapeutic Goods Administration to see if this patient-specific guide can be registered as a Class 2A medical device and used in day-to-day clinical practice, and translating this into actual patient population by conducting a randomized controlled trial at Toowoomba Hospital is the end goal. Thank you for listening. Sorry